Hello guys, so today Tamara, Pavitra and myself Kartini will be presenting about post-operative deep vein thrombosis. So what is deep vein thrombosis? Deep vein thrombosis is a condition in which a blood clot thrombus forms in veins and it can occur anywhere. So it's commonly involves sites are actually iliac and also femoral vein. It usually involves the lower extremities. DVT affects 25 to 50% of surgical patients. DVT in deep cuff vein has 5 to 10% risk of PE. In iliofemoral veins, gas, it has 50 to 60% risk of pulmonary embolism. So, what are the main three risk factors of DVT? As we all know, we have Virchow's triad, which has three main components to it. First being venous stasis, patients who's immobile, paralyzed, and all. The second would be vascular injury, indwelling catheter, and then trauma and surgery. And the third would be hypercoagulable state, protein CNS deficiencies, antithrombin deficiencies, and also malignancy. So guys, let us now move towards the management part. So in this management part, we would be looking at the goal of treatment. So what to do and also how to avoid DVT. Patients undergoing total hip arthroplasty have chance of 54% developing DVT if no prophylaxis has been used. Use of heparin prophylaxis reduces incidence to 16%. And regardless of prophylaxis, 31% of patients undergoing total knee arthroplasty and 27% patient undergoing operation for hip fracture actually develops DVT. So, the goal of treatment is to actually stop the clot from getting bigger. Second is to prevent the clot from breaking off in your vein and moving to your lungs. Third is to reduce the risk of another blood clot. And fourth would be to prevent long-term complications from the blood clot, which is actually chronic venous insufficiency in long term. So for management, first we would give them supplemental oxygen or intubate or give mechanical ventilation, anything according to the patient's condition. And then we would opt for anticoagulant, which would be low molecular weight heparin, enoxaparin 1 milligram per kg subcutaneously. And we can also give them thrombolysis with tissue plasminogen activator 100 milligram over 2 hours. If the condition persists, another option would be surgical or catheter embolectomy. Thrombectomy can also be done for large proximal pulmonary embolism or when the hemodynamic is compromised and it contraindicates to lysis. Usage of TED stockings or compressive stockings is also advisable to avoid post-DVT syndrome. And other options would be usage of inferior vena cava filter when thrombolysis and anticoagulation is contraindicated. And another option would also be catheter-directed thrombolysis. Preventive measures would be divided into non-pharmacological and also pharmacological. The non-pharmacological preventive measure would be the usage of inflatable cuff pumps, which is done intraoperatively, and also to avoid early aggressive ambulation post-surgery. Also, the usage of TED stockings, which is a thromboembolic deterrent. Also, to have intermittent pneumatic lung compression and also good hydration. The pharmacological preventive measure would be the usage of low weight molecular heparin based on risk stratification. That's all from us. Thank you guys.